Assalamu alaikum. We are discussing endoscopic urology here. So our transurethral resection of the bladder tumor here. We saw soft strictures, the bladder neck, and these are the tumors. The number is noted. You can see that the previous resected area was on the trigone and near the right ureteric orifice. So we look for tumors elsewhere. The right lateral wall, the posterior wall, the left lateral wall, and the dome, and then the anterior wall. All is inspected for presence of any tumor. We can see the suspicious vessels all around. There is another small mass. You can press with the hand on the suprapubic area to see if there is any mass. Here you can see that there is another papillary growth on the anterior aspect, 12 o'clock at the bladder neck. This is a patient who is who had a transurethral resection of the bladder tumor T1 and low grade in 2019. He has a recurrence after 5 years. Now he's 24 years old and came with hematuria. On ultrasound, he had two growths of 2 centimeter. So we decided to go for cystoscopy and transurethral resection, and you all saw the findings. So these educational videos are not advanced videos. These are just educational videos for the beginners and new learners and trainees. That's why we discuss and perform the basic procedures. So here you can see that we are resecting the bladder tumor. In a fashion which is called resection in fractions, not in total. We are encountering bleeding in the base. Care must be taken not to go too deep in such cases. Number one. Number two, care should be taken only to resect some half of the tumor towards the base, so that we know where the base is, and then resect the rest of the half of the tumor. We can go in retrograde fashion as well. The patient was given general anesthesia because he was young, and the location of tumors on the ultrasound were such that obturator jerk was expected, so general anesthesia was given. So we have resected one mass. Now is the resection of the other masses. We are going in the retrograde fashion because it is on a very dangerous location. If we go a little deep, we may perforate the dome. So you can see from the diathermy that we are applying the diathermy in pulses and not continuously, to avoid any perforations in the urinary bladder, which is harboring a recurrent papillary tumor, multiple in number, in a young patient who is 24 years old. So we are cutting the mass when some portion of the loop is visible to us, not blindly. We are not trying to go deep, because the deeper tissues will be taken later on when we clean all these resected tissue with the Elix evacuator. Meanwhile, correcting the focus of the camera. So we clean the loop each time so that we clearly see where our loop is landing. If there is a lot of tissue attached and the loop is not visible, there is a chance that we will go deep and cause perforation. Of course, perforation is a big morbidity in transurethral resection of the bladder tumor. Again, we are using pulses because a small mass and can be easily excised or resected with the pulsing current rather than a big mass which will require a more continuous application of the current. So the edges are coagulated. We have resected almost all of the papillary growths, and if there is a suspicion that there is no muscle in the specimen, so we will go for resection and sampling of the muscular tissue or deeper tissue after removing all this resected tissue, and we will send them separately so that histopathologist can easily tell us whether there is any involvement of the muscle or not. So there are no areas of bleed. Here you can see that we are going deeper and we are removing this deeper tissue as we go for resection. Another small papillary mass has been identified, which will be resected later on once we take the muscle for sample. So muscle has been taken from two areas. Here I can see that already there are deeper portions in the resection. The muscle may be there. However, we take some bit of tissue from this side as well. And now we coagulate, as resection will be difficult, we coagulate this and fulgurate this small papillary growth, which seem to be highly vascular and aggressive. And now we come and coagulate the area. I always coagulate the edges first because there are blood vessels running in the submucosal tissue. So if there is cut edge, resected edge of the mucosa, majority of bleeding will be coming from those vessels. So coagulate the edges first and then coagulate the rest of the tissue. If there is deeper resection, even the muscular layer may be bleeding, so that needs to be coagulated. Coagulating around the the mucosal edges gives two advantages. Number one, it coagulates the small multiple submucosal vessels early, and secondly, it also fulgurates the mucosa around the mass or the malignant tissue. Always fulgurate the areas which seem to be suspicious for malignancy. These redness which seem to be carcinoma in situ, but they are not carcinoma in situ because they were not present when we did cystoscopy. So these red areas are because of the trapping of bladder mucosa in the ilex evacuator. So we also coagulate and fulgurate small papillary growths. Surprisingly, these growths were not visible on first cystoscopy when we performed cystoscopy. After making the bladder empty quite a few times, these papillary growths have appeared. Thank you very much for watching.